I appreciate the fact that you're here in Rochester. I also appreciate the fact you survived 2 weeks of on-stop discussion out there. My presentation is not going to be quite as glamorous as this, but hopefully more truthful. So you can do fact checks. I hope you'll find what I say is generally accurate. We'll see. So, as Mega was saying, I am Mayo dePompolo. I am from Michigan, grew up in Detroit, and I've been now in Minnesota. Enough years that U of M means something different to me now. It actually means University of Minnesota. And I talk about the fact that I went to so many games with my son when he was growing up between Michigan and Minnesota. And we kept sort of cheering from Michigan, and he finally turned to me and said, could we possibly attend a different game because I'm tired of rooting for the opposite team. So in the last game I went to, I actually am finding myself rooting for Minnesota now. Musculoskeletal issues are going to be talked about a little bit. You know, we're going to look at the broader concept of where rehabilitation fits into this particular niche of KTS. I have worked with a number of patients over the years, and it varies so much patient to patient, depending on how this is playing out in their life. Rehabilitation in general focuses mostly on functional needs, so that obviously is going to be quite dependent on how this is affecting a person's function. Talk a little bit about edema. I do know that Nicola will be talking tomorrow about this, one of the lymphedema therapists, in greater detail, so I'm not going to go into great extent, but talk a little bit about it. And we'll also talk a little bit about pain management issues. There's a wide range of how this impacts a person's life in terms of pain. A little bit about quality of life, and then vocational, avocational issues here. In terms of musculoskeletal concerns, I broke it into 3 major categories here. One being limb length discrepancy, which can occur, spine deformities, and joint deformities that we sometimes will deal with. From the standpoint of limb length discrepancies, the affected limb is either larger or smaller than the unaffected, depending on how the impact of this is occurring on the extremity. Usually it's more hypertrophic than shorter. Usually does affect the longer bones in the legs than other extremities, or not. It can certainly be segmental. It can affect the hands, feet. To a lesser extent, can even affect the face and the head deformities. Usually it's bone that we're dealing with, but even the soft tissue can become exuberant in the area affecting function. And usually it's the involved extremity that grows faster, but not necessarily. And in terms of leg length discrepancy, the biggest issue here on function is the fact that the extremity on one side is going to be longer than the other, which throws the whole kinetic chain, as we call it, off. That may start down here at the tibia here, but it's going to throw off the pelvis, creating an obliquity or tip. And that's going to affect other joints and articulations, making mechanical stresses where we don't want them. And over time, these little stresses can add up, just like any other moving machine, that if there's enough play in a joint or an articulation, it's going to create problems. And we can then end up with degenerative changes that then create pain and problems. In terms of how to approach it, the biggest issue at the front end, particularly during growth periods, are monitoring. And this is showing the most customary way of doing this clinically, which is measuring the leg. It's not the easiest thing to do, but fairly accurate, from the anterior superior iliac crest down to the medial malleolus on both sides. It gives us a rough estimate about leg length. More refined way are these scanograms that can be done, and the radiologist can get a little bit more accurate measurement than we can. The bottom line is that, up to a certain point, it's probably not going to make much difference. I suspect if we measured everybody's legs here, none of us are truly symmetric. Probably we're going to have some variation here. And as long as it's a half of an inch or 1 centimeter or less, it's probably not any big deal except to your tailor, which we have very few of those around anymore. But they actually used to tailor your pants. But most good tailors would do both inseams because they know there's enough discrepancy. When it gets to a half inch or more, particularly when it gets up to an inch or more, then we start seeing enough obliquity and problems that we then try to make some compensation for it. If it's small enough, the easiest thing to do is to try to compensate by putting an insole into the shoe. The beauty of that, it can be moved around from shoe to shoe, it's not visible, and it works pretty well for people. Unfortunately, sometimes it does get larger, this difference. While we do these measurements, probably the thing the therapist does most is get the patient in the gym and actually tries to compensate either for blocking the one side or using different sizes of cups to try to see functionally what can be done to make the correction. I've often seen though, if we overcorrect, I wouldn't say overcorrect, if we try to actually do the full correction, a person gets used to a certain dynamic, and if we change that enough, we can actually create problems. So normally we go a little bit less than full correction because I think it's tolerated by most people better. And this actually mechanism works pretty well to try to get a sense of what it's going to take to actually make that correction. And if it gets large enough, then we're really looking at making changes to the shoe itself. Simply because it becomes unsafe to put a large insert like that inside the shoe. The downside is obviously cosmetically it changes things a bit, and it limits the number of shoes that you can wear. And for some people that's a big issue, including my wife. So this would probably not be so good. But the other thing that's out there that our orthopedic surgeons can help us with, especially if it's a long bone like the tibia or femur, is to actually try to slow the growth. Now, with that said, what they try to do is the affected limb, which is usually the faster growing one, is to try to interrupt the growth plates on that bone to stop it from growing. The issue is timing, because if we stop the growth too soon, then the unaffected side is going to surpass it, and then we're going to have it go in the opposite direction. If we don't do it soon enough, then the good side, or the unaffected side, is not going to grow fast enough to catch up. And so that's where the monitoring comes in, particularly during those developmental years with the surgeon to see if there is a time to actually intervene or not, or whether it's even worth doing. If it's small enough, we probably wouldn't even venture to do this. Segmental growth can be an issue where we're dealing with an extremity, like the foot here. It's obviously more challenging in some respects to get an accommodation for this. Bracing still does have a bit of a role. It really falls more into the footwear piece of this that we're dealing with at this point to make accommodations. The most common thing for us to do is to try to make a custom fitted insert so that it's full contact, that it gives full support. And then it can be either slid into a regular shoe if the accommodation is minor, or actually customize the shoe. Now, obviously it would be kind of nice to go with a regular shoe for, again, cosmetic reasons and for simplicity, but sometimes it's just not possible to do that. The shoe itself can be customized to some extent to try to improve alignment by changing the heel. This is showing a lateral wedge to try to push the foot the opposite direction. You can do a lot of different sort of modifications to the shoe itself to try to correct it at the foot level anyway. In terms of the upper extremities, these two can be challenging. There's a couple of issues here. One is that we can see imbalances occur so that you can get contractures or deformities, and we'd like to try to minimize that, particularly as the person's getting older, through good stretching exercises. Sometimes we will selectively strengthen if there's some imbalance in the musculature itself to try to get a better balance going with the extremity. And then once in a while, bracing is an option here too, to try to prevent clawing or unusual positioning of the hand. Again, it's very individualized. It depends on whether we're dealing solely with a correction that's bony or whether there's truly a exuberance of the soft tissue that we're dealing with. And of course, that also pulls in the role of good compression in addition to what we're trying to do from this other therapy perspective. And we'll talk about that in a few minutes. In terms of spine deformities, most of these that I see are really created by limb length issues that are again creating obliquity of the pelvis, which then throws off the spine, and you can get scoliosis or a bend of the spine. This is basically an issue because, again, mechanically we're loading these articulations wrong, and it can create problems at all different levels depending on how the person is moving and what they're exposed to, basically. Can be anything from the knee or the ankle up to the sacroiliac joint, which is the joint between the pelvis and the tailbone, up to the spine itself. In this situation, we try to look at the leg length issue, but there is a role here for specific exercise. Sometimes we're trying to do core exercises for the spine to try to maintain enough musculature and strength of the core itself that acts sort of like a natural bracing versus trying to truly intervene with the brace. We tend not to like to do that because then we can actually cause weakness. You know, if we start taking away your power, it will lead to some potential atrophy. But sometimes it's necessary just for comfort, and sometimes during periods of the day it can be beneficial to sort of offload things. Specifically in terms of joints, again, sometimes this is just common osteoarthritis that happens because of overuse or disuse of these joints. Sometimes it can be because of the growth around the joint itself of the bone that can create issues here. But some of the approach is the same way, is one defining where the pain generator is, and if it is the joint, to try to approach it that way. And there's several things that can be done here. Typically, if it's inflammation that's the driver for the pain, then we're going to use anti-inflammatories to some extent. There's obviously pain relievers. There's over-the-counter topical agents. Most of those are counter irritants. It creates heat through chemical reaction or cold, and that does give temporary relief. But there are actually other chemicals out there that we can use. Capsaicin is on the market now. It's basically a chemical from a chili pepper that creates heat around the joint. It's very effective for superficial joints that it can create some comfort with. There's anti-inflammatories like Voltaren, which is in a gel format for superficial areas, can be helpful, so you're not taking a systemic anti-inflammatory. There's patches, there's lidocaine patch, which are expensive, and some insurance companies don't pay for them, but it's a deadening agent. And there are also injectates that are out there. If we have a joint that's specifically involved like the knee, that is an option for us as well. Steroids is the most common one. It's a good anti-inflammatory. It can be used. Other one is hyaluronic acid, which is more like a cushioning agent that we can put in the joint. And one that's more recent on the market are platelet-rich plasma injections. What they do there is they take your own blood, they spin it down, get the plasma, which is rich in platelets and primitive stem cells, and then they put that back into the joint area. And there are some studies out there that suggest for the knee and some of the peripheral joints it can be helpful. Unfortunately, insurance companies aren't really paying for these injections, and they're kind of expensive. So I don't jump into that unless there's really a need to do that. And then again, we're back to the same issue of support. And the two areas there, again, are external support through bracing. And we'll take a look at that here with these sort of more superficial braces, or strengthening the muscles that stabilize the joint. And the knee joint is a joint that is fairly inherently unstable. It's just two basic bones sitting on top of each other, held together by ligaments and sitting on top of cartilage. We can't do much with the inherent stability of the ligament structure, but we can certainly strengthen the quadricep and hamstrings that act like the natural brace to that joint and control function. And that's part of what we'll do. The other thing is whether an actual brace will provide some benefit. There are more elegant braces that do more in terms of trying to unload the joint. This is a knee unloader, and here you have some arthritis that's affecting the medial compartment of that knee. And so the brace is designed to try to push the joint back into alignment there. The downside is that they're very bulky, and some people don't like to have that on. You're going to have to wear it over your pants or your clothing. The upside is that it might provide some relief when you're really active on the joint and provide at least some comfort for a while. So the role of the bracing themselves is to minimize damage to the joint, particularly with upper extremities, to hold them in proper positions so we don't end up with deformities, sometimes to improve safety and to preserve function if we can. In terms of edema management, again, it's hard not to talk about this when you're from the physical medicine perspective, because that is the big issue sometimes that we're faced with, and it limits our ability sometimes to treat these other orthopedic issues when we have an enlarged limb to deal with on top of that. Swelling can be caused by a number of factors. The actual AVM or arteriovenous malformation itself increases the amount of flow. It engorges the tissue. It throws the balance of fluid off. It can affect the actual lymphatic system, which we'll see here shortly. But also there's a change in lifestyle with individuals. They're not using the extremity as much. There's not the same muscle pump function and the same muscle support. And that can create problems with fluid management. And then when I'm seeing a patient for the first time with edema, the important thing is to make sure there's no other secondary cause for that edema. It seems like nowadays, whenever I get a patient, everything's lymphedema. Even when we know there's a vascular component to this, it's still billed as lymphedema. And it is important sometimes to separate those entities out, especially if there's systemic issues, cardiovascular issues, sometimes renal, liver, to make sure that, especially with an older individual, that we just don't blame it all on the KTS. So this is trying to explain a little bit about what lymphedema is, or about edema management in general. Everybody knows sort of about the vascular system because we learned about it in school. The heart pumps out the blood through the arteries. It goes to these little arterioles and gets down to the cellular level. The vessel is small enough where fluid exchange can occur, and then it comes back to the small little venules, and then back to the veins, back to the heart, and it keeps pumping around that way. And that's where a lot of fluid management happens through the interstitial tissue. There's pressure in the vessels themselves that force it out, and then there's osmotic pressure, which is the pressure gradient that occurs because of what's in the vessels versus what's in the tissue, which will make fluid move back and forth. On top of that, you have this more open-ended system called the lymphatic system, which is the one that we sometimes are dealing with. This system is sort of separate from the vascular system. It's open-ended. These are little tubules that are out there. I like to tell my patients, especially in Minnesota, we have lots of farmers. It's like the tiling you do inside of the farmer's field. It's very passive. It just sits out there. If there's enough fluid, it will seep into those tiles and then drain into the ditch. That's what basically happens. These are loose-fitting cells. It does allow fluid in, and then it will bring it through the system here. And this shows then it's intimate as part of the arteriovenous system, but it's sort of separate. It does bring fluid through the lymph nodes. The lymph nodes' basic purpose is to act sort of like a water reclamation plant. That lymphatic fluid is usually full of larger cells that can't get into the veins and arteries. It's got debris in it. It can be cancer cells, can be bacteria. It goes through these lymph nodes, which are really part of your immune system, where there's actually T cells. There's the cells that can recognize foreign, attack it, and control it, so that when it eventually gets dumped into the vein, it's pure in terms of fluid. So it has definitely a purpose, and there's a large pattern of lymph nodes throughout the body here. When this system starts shutting down, though, it creates big-time issues. As it was pointed out, this lymphatic system is intimate to the arteriovenous system, so it's easy to see how it gets involved when there's problems with AVM. It also it's very fragile, so any kind of pressure, any kind of push will obstruct its flow as well. And if you pressurize it, it'll blow, for sure, the little pumps that are in the lymphatics that helps move the fluid. And this is just trying to put it all together here. So, compression is probably the foundation of our treatment to this. We will talk briefly about a few other issues, but this is sort of the gold standard. There's compression wraps, garments, devices, and it is what we sort of see as the foundation of our treatment. This is a bit of an art to get this to fit on a person correctly, and I've had plenty of patients who come to me and say, I've tried this already, it doesn't work. It often is because the padding's not properly applied first, and if you don't pad the low spots and allow the compression to work effectively, you're not going to get the benefit from it. So there's plenty of pads, there's cushions, there's cotton rolls, ways to pad it and distribute the pressure properly, put the pressure where we want it. Once we get this down to a certain size through this wrapping technique is where we'll try to switch over to something that's less labor intense. While wrapping is the gold standard, it also is very hard to do often. Garments themselves, the fitting of a garment is a bit of an art. The other thing that I see as common failures is as you have a large extremity and you try to fit it right at that point. And that doesn't usually work very well because you can't get a good fit on a large extremity, especially if you're trying to deal with an off-the-shelf garment, which is made to fit a standard extremity. And I often get patients who refuse to even think about wearing these initially because that's what they have in mind. Well, I was putting this garment and it hurt. It actually made things worse. There's a bit of an art to get the proper garment, the proper compression in the garment, and also the proper material. And then even putting it on, taking it off is an issue. There are aids out there to help. We can be shown how to do this. It's not as difficult as sometimes it seems. In addition to that, there's a wide range of other things out there these days for edema management. Most of these other things are adjuvant to the actual wrapping and compression in the garments. Whether it's massage techniques, and I suspect Linda will talk a little bit about those, manual lymphatic drainage and decompressive massage, or there's a low-level laser that's been reported to be beneficial to break up some of the indurated tissue that's there. There's a egiotaping that's trying to direct the flow of the fluid. There's pneumatic pumping. You don't see it very well there, but that's the acupuncture up there. None of these really have a lot of science behind it. Even the massage techniques are rather questionable as to how much beneficial they are. I think they're helpful if you have really firm indurated tissue from chronic lymphedema, but any of these are not going to replace the actual, compression that we've been talking about. And then there's a lot of other options here for compression. There's Velcro closure devices for people who can't pull the stupid thing on. They live alone and you're trying to get a sleeve on at the arm, and you're one-handed trying to do that, probably doesn't work so well. But there are Velcro closure devices out there. There are nighttime devices that can be used at night. Sometimes we try to complement the daytime with a nighttime program to make sure that we minimize the edema as possible. In terms of pain, there's a lot of potential pain generators. This is actually from Dr. Driscoll, who's sitting up here. But what's important here, it is a very important issue with patients with KTS. A large number of people have debilitating pain that affects their function. And trying to understand where that pain is coming from and approach it properly is important. And that, again, can be a role for rehab. Some of these things have been talked about already that can cause pain. But things like neuropathic pain, arthritis, Some of those things fall probably more into the area of the musculoskeletal providers like rehab folks. And this is the chronic venous insufficiency issue. In addition to standard lymphedema and arterial venous malformations, once you start pressurizing the venous system, you can easily interrupt these one-way valves that are in the vein. Once you make them incompetent so they leak, then you end up with a stasis issue. So now we have a lymphedema piece, an AV malformation, and probably some incompetence of the valves themselves in these little vessels, which create problems. As was already pointed out by Mega, you can end up with chronic changes of the skin, which can lead to other issues. There are interventions for these things. Most of the time, these interventions help, I think, a little bit more with the pain control than they actually do with the edema management part of this. Cellulitis, I think that's been pointed out again. The important piece here is that we want to prevent this as much as possible, and that's through proper edema management, fluid control, and good skin care, basically, so we don't get into that situation there. And then there's the superficial thrombosis and the more deeper thrombosis that are critical to pull out if somebody's coming in with a painful extremity that hasn't been painful before. And even though it's been swollen, it hasn't been painful. It's important to make sure that there's not something else that's driving this. Quality of life. Unfortunately, because KTS is a very small, rare kind of entity, there's not a lot of science behind the rehab piece of this. There's not studies out there that are looking specifically at rehabilitation interventions for patients with KTS. There are a couple studies out there actually looking at quality of life issues with individuals with this disorder. And it's pretty clear that the studies that are out there do point out that when you compare individuals with KTS versus the general population versus individuals that have other medical issues, that there is lower scores in the area of physical function and bodily pain than there is in the general population. Also, it appears that with KTS, that the actual functional ability is impaired, much greater than age-matched peers out in society, or even people with other chronic medical issues. Rehabilitation can provide some support there through counseling especially, but also trying to minimize these functional impacts on a person, because that is really the main goal or thrust of a lot of what we've been talking about here. Exercise in general, don't they look happy there? Maybe that's what we all should be doing, is going to the pool here. I'm not sure a aquatic program is often the best program for people. For a lot of reasons in the Midwest, it's hard to find a pool. But, it is a great exercise. The whole idea of exercise, stabilize the areas involved by using the muscle function you have. Optimize the flexibility. And also improve the conditioning, and by that improve function. And there's probably an actual improvement in attitude. There's a question whether that's something that happens with exercise or whether you just start feeling good about yourself, or you're a social animal and love to be in a group like this. It's hard to say. But there's definitely a role for exercise in this population. Another issue that once in a while we deal with are vocational avocational issues. Again, depends on where we're picking the individual up. During the school years, the school itself can provide some of these interventions, particularly in secondary school, where if an individual is having a functional or a disability, trying to help that person assess what their abilities are, taking a look at what their interests are, can be a big step in taking a look at career choices that the person might be thinking of. Later in life, if the symptoms worsen, trying to reassess what the abilities are helpful. Try to get potentially the paperwork in line to try to do some modifications to the job site if that's appropriate. And that can keep a person engaged with work, if that's what their goal is, for a longer period of time. There's actual work rehab programs and capacity evaluations that can be done that can objectively measure a person's function. Whether we're looking at trying to support a return to work or not, that can sometimes be beneficial here to get an estimate of what the person can do. In Minnesota, and I suppose most states, there's also state-level vocational rehab offices that are available, particularly for a younger person in their 20s, 30s. They may be found eligible for services by the state. What that's nice for is that they can offer counseling and training and monies for job skill training and stuff like that if they're felt to be qualified. So this is another resource that once in a while we will use to try to help direct the patient. It is dependent, at least on our state, on ability to pay. And if you're on SSI or SSDI already, those services are paid for by the state if you get qualified. And they're going to take a look at whether they have a good chance to return you to work or not with these types of interventions. The other thing that occasionally we're looking at is just the application for disability, and that too can be helpful to have a well-documented note in the chart that says specifically what you can and can't do, because otherwise you have somebody who's at a 7th grade level trying to read a chart to figure out what this all means. And if you can bring it down to functional terms like this, I'm not saying everybody's that, I'm not. But I think that if it's well documented in terms of what a person's abilities are and limitations, that can be helpful to speed the process through the system, if that's where this is all going. So overall, what our goals have been, other than, so I actually have both the conventions here, in case you could tell one from the other. They both looks the same to me, a lot of hot air. Basically, what rehab comes down to is trying to optimize function, and whether it's trying to optimize that to maintaining proper strength and or conditioning, minimizing pain, or whether it's trying to control the swelling. So we see a wide variation. There's a lot of territory to cover. I hope it was helpful. Thank you.